introduce Dr. Ben Curtis. Born and raised in Wills Point, Texas, Dr. Curtis was inspired to become a pediatric dentist after the poor dental experiences he had as a child. He strives to make dental visits fun for kids by providing gentle and compassionate care. Dr. Curtis graduated from Texas A&M University with a BS in biomedical science and a minor in business. He went on to obtain his DDS and pediatric training from Baylor College of Dentistry. He and his wife, Rachel, are proud parents to Birdie, Dodson, Emerson, and the newest, Goldie. And on a personal note, Dr. Curtis is a good friend of Waterlase Education's and does a wonderful job educating clinicians about all tissue lasers. So we're definitely excited to have Dr. Curtis back doing tonight's lecture. Dr. Curtis is coming to us from Telluride, so there's worse places to be. And I did want to mention, big year for Dr. Curtis in 2022. He opened up his own practice, Curtis Kids Dentistry. So Dr. Curtis, we're excited to have you and looking forward to your lecture. Take it away.
Awesome. Thank you all so much for coming out this evening to hang out with us. Like Joe said, I'm here in beautiful Telluride. I made sure to position my computer so you could get the sunset here over the mountains with me. So I might be coming in some weird lighting, but it's worth the view for y'all. So I'll share that with you this evening as well. I always get so excited to be able to talk about different laser topics with y'all. And I always get so excited to see where everyone is coming from. So we've got people from all over the US, from Indonesia, from Romania, from Germany, from Australia, from Argentina. So thank you all for taking the time out of your busy days to better help your patients in your communities and your parts of the world. What we're going to be focusing on tonight is going to be frenectomies, and we'll be looking at it from infancies through adolescence and using an all-tissue laser to help out our patients with those. Okay. So who am I? First and foremost, I'm a dad. As Joe said, these are my 4 kiddos here, Birdie, Dotson, Emerson, and Goldie. We live on a ranch out in East Texas, about an hour outside of Dallas, right where it turns into the middle of nowhere. It's a fun place to raise a family. I grew up there. My wife grew up there. And so we're glad to be able to have our kiddos grow up there as well. This is our one of many cows that live on the property, and this is Muna, she's affectionately called, and she actually just walks up into the yard, so she just comes out of nowhere all the time. So she's really sweet. She thinks she's more of a Great Dane than she is a bovine, so we'll keep her. When we're not on the farm, we're at Disney. My wife drank all the Disney punch. So this is us just this last Halloween. We took all the kiddos and we went to the big Halloween festivities there. And little Goldie, you can see her down on the bottom of the screen down here on the airplane. So we had a really good time there. Do my dental school at Baylor. This was one of my buddies from dental school. This was us on injection day. If you look really close, you can see he got, he aspirated blood into the carpule. He hit the IA nerve right on the money. He's now an orthodontist, so he doesn't have to worry about giving injections anymore, right? I had the great privilege of being on staff for many years at the Children's Hospital in Dallas, Texas. I since have given up my privileges there as I moved out to East Texas, but I did my residency there and really loved being a part of serving the children there at the hospital. I'm a board certified pediatric dentist and a diplomat to the board. I did a great Harris Fellowship project through the American Academy of Pediatric Dentistry, and the late, great Susie Seal, who is the editor-in-chief of our Pediatric Dental Journal and the past program chair there at my residency. She was my program chair for my Harris Fellowship project, where we looked at ways to help improve advocacy for children across the nation. And through her, she really instilled in me a great respect for education and helping others in their educational processes too, through things just like this. So I credit her with a lot of my desire, passion, and advocacy for education. I spoke this last year at the AAPD annual session, the 75th anniversary for AAPD. So I spoke on laser dentistry there at that. I am the president of the Southwest Society of Pediatric Dentistry, and we do a ski meeting every year, and we're in Telluride. So the ski meeting is actually this week, so that's where I'm coming to you from. If you've got a chance to make it out to the ski meeting, it is always a great event. And Waterlase was so gracious to help sponsor that event this year. As Joe said, I just opened up my private practice out in East Texas. We're in a more rural community, and we are a laser pediatric dental office, and we are booming out there because there is such a great need in our community for these sorts of procedures, the same procedures that I'm going to share with you tonight. I was featured actually this month in Dental Town magazine. So if you're a dental town, a townie, then you'll be there and you can see my article and a write-up there. So that's exciting news there about tongue ties and the all tissue laser. This is the laser I utilize in my private practice every single day. It's the Waterlase I+ laser. It's a cool laser that uses water to help kind of cool the tissue, and it really has a minimal impact on the tissue. It doesn't burn or char, but it really is kind and gentle to the tissue. So I really love it for my hard tissue, for fillings and crowns, and also soft tissue things such as frenectomies. As Joe mentioned, we have a very exciting meeting coming up this year, Tequila and Tongue Ties. It's our second annual event. Last year was a smashing good time. And so we're back again at it again. This year it's going to be in Scottsdale, Arizona. Registration is open and we still have spots available. And we're encouraging you to bring your entire staff. It's going to be a successful practice approach. So making sure that we can help you be successful in your communities at home with your as you're treating tongue ties, not treating tequila. I do a lot of educational things, from in-office trainings to webinars to large group things. And so I really am passionate about helping with those things. And I'm always appreciative to Waterlase for helping these things be possible. How did I get into lasers and get into that? Really, I went to work as an associate at Dr. Rena Kuba's office in far north Irving, just above the airport in Dallas. And so we had a very international population from all over the world. And she just threw me into the laser world and said, you've got to do this. This is just going to make such an impact for you on your practice. And I thought it was voodoo at first. And I was like, no, man, I am not touching that. That voodoo box over there with lasers and all this. Like, I've been classically trained at Mother Baylor, and that was not part of it. But through her kind of gentle nudging and encouragement and things like that, we pioneered ways of doing things. We were mavericks of sorts, figuring out different ways of doing this in pediatric dentistry, because, 5, 6, 7, 8 years ago, these things were not as educationally available to us pre-COVID. And so there just weren't as many educational opportunities. So out of that hard work that was put in on the private practice side, we bring to you the educational fruits of that. My goal for you for this evening is really to keep an open mind for your pediatric patients and how you can help make an impact for them within your community. Even if you're not the one that's doing these procedures, you can be an advocate for that baby. You can be an advocate for that child. You can be an advocate for that adolescent to get the care they need. Make a proper referral for them. It really can change their life. When I think about lasers, I think about Dr. Maya Angelou. She teaches us that you do the best you can until you can do better. And when you know better, you do better. I was the best trained pediatric dentist to be the very best that I could be when I left my residency. And I knew the cutting edge of everything and the proper approaches, everything that the literature taught us in and out, from private practice to educational, all these sorts of in and outs. And that did not involve lasers. And so for me, this was not the way of doing it. But as I quickly saw, this was better than what I was doing initially. It was better outcomes for my patients. It was quicker treatment. It was really efficient. The child enjoyed it, and the parents really saw the impact of how this really helped their kiddos. And so I was doing the best I could, but there was a better way. And I hope that tonight you can see that this is the better way and that you too can do better. All right. What we're going to focus on this evening is identifying indications for infant frenectomies And then we're going to walk through step by step for those with the all tissue laser. Then we're going to focus on those same procedures for child and adolescent patients. And then we'll walk through those procedures step by step as well, okay? I only have an hour with you, so we're gonna make a running course through this, okay? One big takeaway for us when we're looking at restricted tethered oral tissues or tight oral tissues or tongue ties, lip ties, whatever you want to call them, we wanna make sure that we're understanding how the symptoms and the function and the anatomical structures all fit together for a proper indication. Without understanding all three of those, we're really not going to have the best results or the best impact for our patients. So when we're approaching those, we want to make sure we understand how all of those fit together, okay? And when we're looking at infants versus our child population, there is a great divide, okay? The continental divide on kind of what these symptoms are, what the signs are, what the anatomy looks like. And so we have to understand that depending on the age group and what their needs are, that we're going to have to approach that differently, okay? So let's start off with some general symptoms for an infant, okay, as it relates to lip and tongue ties. Let's start with the mother, right? Why would we think about the mom? We never think about the moms. We're not trained to treat the moms. We're trained to treat the child. But when we're thinking about infants and we're thinking about tongue ties and lip ties, we must think about the mom, okay? She is breastfeeding or she is bottle feeding and she is struggling to provide the nutrients hour after hour after hour that baby needs to survive. And breastfeeding is not easy, particularly for a first-time mama. And so we really want to be listening to what struggles she's having, not just what the struggles the babies have. And so that's normally my first questions are related to her. I'm talking about her and what she needs to tell us about, not the baby necessarily. And so we start with mom. I want her to know she's important in this process too, okay? If we're having nipple pain, there's a problem, okay? We need to be looking more into that and not just shirking that off as saying, well, it's just normal that you're going to have some nipple pain. We hear that a lot from pediatricians, okay? But really, we want to be digging in more to that to make sure that we're paying attention to that symptom. We have these poor moms that will have blisters on their nipples or cracked and bleeding nipples. I had one patient that spit up blood because he was eating so much more blood out of his mother's breast than it was actually breast milk that was getting down. So that was quite disturbing. Lipstick shaped nipples. So if they get malformed from the baby and they crunch that into the baby's mouth as opposed to actually suckling the milk out, they're just crunching the nipple, that can cause a malformation or a deformation to the nipple and the breast tissue itself. Without extracting that milk appropriately, you're going to end up with engorgement and swelling, and then abscesses and mastitis in the breast that can then lead to more antibiotics or surgeries needed to take care of that. And then it's no wonder that these moms with these poor babies have a higher risk for depression as it relates to that. And so it's a very fragile community that we want to make sure we're respectful to these moms, okay? Don't ignore the mother, all right? Those are key parts of what we want to be taking into effect for our considerations. Let's think about the baby themselves. What sort of things should we be thinking about, okay? These are all sorts of things that I'm asking the mom about, or I'm observing, or we're looking for, or the pediatricians are sending me saying, the baby's having this, 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 and this. Will you please evaluate them for a lip and tongue tie? A shallow latch. If the baby cannot latch on the breast and they slide down the nipple, that is going to cause more pain, less extraction of the milk, and the baby is going to be using a lot more energy to do that. So they must have a proper latch. I am not a lactation consultant. I am your surgeon. And so I'm not here to talk to you all about the proper latches and how to achieve those, but I'll make the proper referral for the lactation consultant if that's the mom's struggle, okay? So we don't have to solve all the problems, but we want to be helpers there as it's multifactorial, okay? We may notice that the baby just slides off the nipple and won't want to stay on there. They get frustrated and fussy, or they even feed so much they just fall asleep. They get bored, and then they wake up hungry again, and then they nurse till they fall asleep. So that can be a really big struggle for some of these moms and some of these babies. I'll show you a picture here in a minute. One of my cases that was out of the Dental Town magazine, where the child was actually sucking in so much air, he would bloat up like a balloon every time he would feed. The mom would have to use what's called a windy that you put into the posterior portion of the patient to let out the gas, okay? And so it's a windy if you haven't seen those. They're very helpful in bloating children, but there's a reason the child is bloating. So we don't want to treat the end results. We want to be treating the initial results, so then we can get resolution and the mom doesn't have to use the windy. So we'll talk more about that in a minute. Clicking and smacking, that baby should not be every time. I want you to do that. It is hard for you to swallow your spit, and I gulp air when I do that. That gulping of that air gets into the GI tract, and it causes them to have all sorts of GI disturbances and causes them to have all sorts of pain. I have mothers that come to me saying, my baby just hurts. You can just see them just riveting in pain and discomfort for an hour to 2 hours after every feeding. And so the child is using all of this energy to do that. The mother's using all of this energy. And that's not just breastfeeding babies. These are bottle-fed babies that are trying all these different bottle systems, are trying all these different formulas and everything to try to help these babies. And that's not the root cause of the problem. The root cause of the problem is the anatomy is restricting the function that is not allowing it to function appropriately. And so that's really where these symptoms are all going to relate together. I've had a string of spitting up, vomiting babies. I'm not talking about just spitting up some, that can be normal. I'm talking about projectile, like the mom is saying, like literally, if you could measure the vomit, it would fill the bottle that they just drank, and it will splatter against the wall. I've had a recent uptick of those lately too, and that's been quite concerning for me. I've also had some recent babies that have really struggled with tummy time, where they don't want to be on their stomach. It's painful. Like you can just see, I even flip them over when I'm looking at them on my exam changing table to see how they're interacting in this tummy time. Like, are they moving, or is it a struggle and a pain for them? And so really evaluating those sorts of things can really play into this tethered oral tissue. So it might not necessarily be the feeding problem, but it could be tummy time issues or acid reflux and GI issues that relate to that. Here's this sweet baby. The picture on the left is what it looks like after the baby feeds. The picture on the right is what it looks like less than 24 hours after the frenectomy. So the baby had never not distended and bloated after feeding, but immediately after doing the tongue tie and lip tie release for this baby, we were able to improve the latch and improve the feeding. And just to note, this was a bottle-fed baby, not a breastfed baby. The mom had been through all the systems. This was a NICU baby that was delivered early, so they weren't able to breastfeed, and it just wasn't working out. So this is getting that much air through bottle systems, okay? So it's not the breastfeeding mom that's not trying everything. This mom has literally tried it all, and this is what she's getting with the best efforts, okay? And this mom is driving from our rural area into Dallas, Fort Worth to the best pediatricians she can find to get this baby the best help. I mean, just look how uncomfortable that is. So this is the mom that has to use the windy to help release that gas from the GI tract. So what a great impact and a quality of life we've made for not just this baby, but for the mother too. Now she can actually rest and relax and take a breath, knowing that her baby is on a better track, all from a simple little procedure that took less than 5 minutes. Clinical signs. So those are kind of symptoms and things we want to be looking at for these babies, but we also want to be thinking about the clinical side of things. So not just what systematic issues, but we also have to tie it to clinical things too. I like to compare it to, we don't just treat a cavity based upon an x-ray. We have to look at it clinically to see how the best way of treating that is. Same thing with the mouth and with these tongue ties. We can't just go off the symptoms. We have to go off of the anatomy as well. And some signs that we can look for in the mouth. I want us to look at this top picture right here, this top left. Do you see this chapped little callus area? That can be very common in these babies that are using their lips. This orbicularis oris muscle is a round muscle around your lips, and you squeeze it together, and these babies are actually biting the nipple or biting the breast, and so are actually extracting the milk by breath, and then they swallow it, and they swallow it. So they're using these lips inappropriately because they can't make the great Instagrammable duck face. They can't do that, okay? So they're not an Instagram sensation of a baby, so we need to help that, okay? I'm kidding. But those are big things we want to look for. I actually have babies where the mom has fed them and she's shown me the bubbles that they get on their lips. Like literally there's like bubbles, blisters that can form. So if a mom's telling you that, she's not making it up. I've seen it myself and it is very disturbing. It's from the friction, and those tend to get swollen like edema, and then they go away. They swell and they go away. There's even babies that give themselves mucoseals from the exact force that they're using to extract this and to eat, okay? What we want to be looking at too is how we're elevating that lip upward, okay? In all of these examples, we are not getting the actual lip up to the nose. You're scrunching the lip up. You can't roll the entire lip out. If you look at this top right example up here, this is a great example. This is the actual lip that you would paint your lipstick on. This is the external part where you'd grow a mustache, okay? You need to get the lipstick to the nose, not the mustache. Do you see the mustache, okay? We don't want to get the mustache zone. We want to get the actual lipstick, okay? You should be able to get the lipstick on the nose for these babies, okay? This is an inappropriate flange of the lip. By releasing that tissue out of the way, now we're going to be able to lift the lip all the way up. You'll notice on each of these babies, do you see how pink this is? And then right when you get to the alveolar ridge, it's blanching so much, okay? You can see here how it's pink, that it's blanching. Why is it blanching here? Because my fingers are having to hold with such force to lift the lip up. So I'm actually blanching this side of the jaw with my fingers, okay? So this is how I'm assessing the lip attachments, okay? And seeing if I can get that lip all the way up to the nose. What are some things we want to look for the tongue side of things, okay? For these babies, I'm sticking my finger in there and lifting that tongue upward. I'm elevating those tongues, and I want that tongue to go up more than 50%, okay? So if I'm cranking this mouth open, I want to be able to lift that lip, that tongue up, and I want to get it to the palate, okay? That's what I want. And you can do it, okay, for a not tongue-tied baby. But if you can't get it more than 50%, then we're starting to get more concerned here, okay? So this is going to be an anterior attachment on the top left. The bottom left would be anterior. The bottom right would be anterior. This is going to be more of a posterior, okay? It's crossing farther in the back, okay? What I want you to see is how my finger is sliding around this. Oopsies, let's go back. Sliding around this, okay? As I run my finger across this, I call that a finger sweep barrier. You are going to play that like a guitar string, okay? There is not like this squishy, flexible tissue. As you lift that tongue up, you're just going to dun, 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 dun. You're going to play the guitar, okay? There's also this Eiffel Tower look. I'll show you more of that on an older child, but you can kind of see this Eiffel Tower-ish appearance. Now, I want you to look at this and look at this. That belongs in the floor of the mouth. Those are your salivary glands that are getting pulled up out of the floor of the mouth by that tissue. The actual frenum in this baby is only that long. The frenum is only that long. The frenum connects the base of the tongue to the floor of the mouth. The floor of the mouth is getting pulled up here. That is inappropriate, okay? That is not a good anatomical situation, okay? I want you to reach your finger up and feel that palate. A lot of times these tongue-tied babies don't get their tongues all the way up to the roof of the mouth. They can't do it, and it creates air. it creates space. And so now the baby sucks even more air. So if we can get that tongue up higher to that high palate, then you're going to be able to close the space more and get less air in, okay? Over time, by having a tongue that can go and rest up on the top of the roof of the mouth, we'll actually be able to reform that palate more. But the reason that palate is like that is probably because the tongue can't get up there and shape the palatal growth, okay? And we're using all of these muscles that squish the bones together. The bones do what the muscles guide them to do, okay? And so we really want to be paying attention to that high palate. That's a red flag. Another red flag is a coated tongue, okay? If you see like that Candida fungal looking tongue that you're like wiping off, you're like, okay, that's not a fungal infection. That's just a plaque of milk. That's because the child is not physically frictionally rubbing their tongue on the roof of the mouth and actually debriding off that, okay? They can't get that tongue all the way up. It's not functioning appropriately. That tongue should not be coated like that. So if we're seeing that, that's another big red flag, okay? So let's walk through our step-by-step techniques here for a baby, okay? We're gonna take this over several slides, all right? So first, you want to take pre-op photos. As you can see, I'm always taking these photos, okay? So those photos help us to be able to see where we started, where we finished, all right? So you always want to be taking these pre-op photos, okay? I like to swaddle my babies out. You can use one of these little Velcro swaddles. I like to use the big swaddle blankets. I've had 4 kids. I'm a pretty good pro at swaddling. I get these parents all the time like, oh, my baby doesn't like to be swaddled. Good luck. I mean, I can burrito wrap that baby really good. They love it, okay? It's just the parents don't know how to swaddle them, okay? Laser eye protection is key. You can use these little suntan goggles that are laser appropriate that you can get, but they tend to move all around. So I like to use these laser eye patches that you can order, and then I like to take surgical tape and tape them over it. So that's surgical grade tape right here. So that's my preference. That way the eyes are protected from like any splatter or anything, and they're also protected from the laser, okay? Other things for us, high-speed suction and gauze is a must, okay? What if you get a bleeding? What if you get like vomit or something or spit out? So you wanna have high-speed suction and you wanna have gauze. I like to do these in a lap exam style where it's my assistant and I, and if I've got another assistant there that can help like hand us things, it just makes it go faster, okay? This is not a 15 to 30-minute appointment with 2 assistants. This is like a 1.5-minute appointment where you needed 2 of them, okay? And then the other one goes on to whatever she needs to do. I also like these cushion boards, so we can lay the baby back on a board, or you can just lay them in your lap. But sometimes it's nice to have these little foam boards that are a little bit more of a firm surface to have them on. I like to use my all tissue laser. As I said, this is the Waterlase I+. The handpiece is very similar to a high-speed handpiece. It feels that it's lighter than your high-speed handpiece. It's not heavy. It has a little tip, a little light. It sprays a little bit of water. You can adjust the water so you can turn it down. For my babies, I like to turn it down to just a little. That way you're not suctioning more out. It just like a little spray. It still helps cool the tissue, but you don't get as much in the mouth. So you're not having to suction as much, and it's not an aspiration risk at that point. I like to use an MZ5 tip, which is a small little cylinder tip, and it's got a really nice finite cutting length. So if you're you're not touching the tissue, you're about 1 millimeter away from the tissue, and it has a very safe working length. If I'm 3 millimeters away, nothing happens, okay? So if the baby moves, nothing happens, okay? So I've got to be in 1 millimeter to make it work. There's also one that's called the chisel tip that you can contact the tissue and touch it with, but I like this MZ5 tip the best, okay? And built into this is an easy touch screen, and I don't mess with the settings. I just use these factory settings that work great, and I like to use the frenectomy settings. So you can go soft tissue, frenectomy, and then away you go. So it's pre-programmed for you, really easy to use. For the lip, we want to raise that lip up. I would use gauze to hold it with your left hand. That way you don't slip, okay? It's going to get kind of slimy. So we want to be holding it with gauze to retract upward. I hold it and hold firm pressure. I start at the ridge down here, and then I'm going to be tracing it upwards towards the nose. There's two different techniques for this, where you could go a vertical incision, so like from the ridge up to the nose, or you can go laterally. I like the lateral move myself, okay? And so you're gonna hold pressure as you lift the lip outward, and you're gonna chase those fibers upward, okay? Here's a little video here that's going to show us a little bit more of what we're looking at. It's kind of hard to get good videos of the babies in their mouth doing these. So this simulated one gives us a really good kind of concept here. So I like to start right down here at the bottom, not in the middle. The reason is if you start in the middle, you're going to end up with this tissue tag down here. They're starting at a very acute angle. I would start more from this direction, okay? Kind of like where they are now. I don't like to aim it up so high. And then I move laterally back and forth to release the fascia underneath, okay? When I take my finger, I rub it across this area to make sure it feels nice and elastic and smooth. If I feel any tight fibers or tight tissues, I'm gonna go back over that and release it, okay? If you get any bleeding or anything, there's a built-in setting here that helps with coagulation, it helps with healing, called a laser bandage setting. And so that can be really helpful if you've got a little bit of bleeding there. As you finish these, you're going to sweep back and forth, and then you end up with this diamond shaped, okay? It's kind of hard to visualize it here, but now you can see that I got the lipstick to the nose, okay? If you ran your finger across this, it'd feel nice and smooth, okay? We don't have a ton of bleeding. Sometimes you get a little bit more bleeding, but we've got a nice clean there. I don't have any tissue tags hanging here or any weird tissue hanging down there. You do not want to touch that papilla right down there. There's a huge nerve bundle. Leave that alone, okay? Even if it's like hanging down, I tell the parent, you want that there. You don't want me to cut that off, okay? So I'll tell them that beforehand, okay? So if you end up with this little notchy, don't go after that. Leave it alone, okay? And then always take your post-surgical pictures, okay? That way you can document what it looks like, and then we'll have them come back in a week to 2 weeks for a post-op visit where we'll take another picture. So here is a baby frenectomy. You can actually see that this baby has actually torn it some already. Do you see how this was down there more? So they have a little tissue tag there. And so we still can't get the lipstick to the nose. It's only the mustache. And so I released the tissue up there. A week later, look how beautiful that is healed. In 1 week, it is pretty much done healing, okay? And now the lip can get lifted out, no scarring, a beautiful heal, okay? So let's go for the tongue tie now. So that was the lip tie. Here we go for the tongue tie. It's the same exact setup from here, okay? We're gonna take our pre-op photos. We're gonna swaddle the baby up. We do the laser eye protection. We're gonna have our high-speed suction and our gauze handy. We're gonna have our tip on that we like, and we're gonna use the frenectomy settings there for our laser. So I like these Netter-esque drawings here because they really help us conceptually see how we're going to help support the tongue, okay? One of the most common tools that we can use to lift the tongue is what's called a groove director. You can order these on Amazon. They come in different sizes. Sometimes they get called the Mickey Mouse stick or the Mickey Mouse ears. They have ones that come in like wood or bamboo, and you can send those home with the parents too, so they can do post-op stretches and exercises with those. There's even like a plastic one you can put on your finger called the lipper that you can use to help do the stretches. You could do the procedure with it and then send it home with the parents as well. I like this groove director because it's got this long handle here to it, and so you can just reach in there, and you're not having to be all up in the business. You literally lift up the tongue, make your lateral incision in the middle, okay, and then you're chasing it backwards. I do not recommend to make the incision at the base of the tongue or at the base of this groove director or at the floor of the mouth. There are vessels and salivary glands down here that will be very hard for you to see when you lift up the tongue. The tongue sometimes drops through and you'll cut into the muscle of the tongue or the vessels of the tongue. Those are both two anatomical areas you want to avoid. For one, it increases bleeding risk, but more, it's going to cause way worse postoperative pain, discomfort, scarring, and prolonged healing, okay? I've had to manage a few kids that have found themselves in those situations from other providers, and they've come to me because they're just struggling healing with this, and it was because the incision was not appropriately positioned, so their surgical site got off. So you always want to make sure that you keep a clear surgical site. We're not rushing, and we're identifying where those attachments or where those anatomical landmarks are. And the best way to start that is making it in the middle, okay? Let's watch a video here. Once again, it can be kind of hard to see, so sometimes these little animated ones make the best for kind of commentary. So we lift the tongue up here. What they're using is hemostats. I would not recommend using that because you're going to crush the tissue. They're making it at the base of the hemostats. Once again, you're risking getting into the muscles and you're risking getting into the vessels down here. So make it in the middle, and that's a much safer spot to go through. We would be rubbing our finger across this area, making sure we didn't need to release any more on the soft tissue, making sure that the fascial fibers are all released in the area. Right now, it's pretty trendy or in vogue to put a little stitch here, here, and here to help close those together on our older children, but not on the babies. So you might be reading more about that. So sometimes that can be something that can be positive, but it doesn't have to be done, okay? We leave these open. After we release those tissues, we want to make sure, once again, we're doing that finger sweep to feel over it. So this baby here, we're going from here to an anterior attached forked tongue, lifting it up with the groove director, making your incision here. Here's your diamond shape, minimal bleeding. That'll feel nice and squishy, okay? Avoid the salivary glands, okay? And then you take your post-op picture and you're done. Here's another example here of a baby that was the second baby for this mama. Had a severe finger sweep barrier. You can see the attachment all the way to the tongue. Immediately after releasing it, it almost just closed itself. It's almost like we didn't do anything. That baby felt no discomfort, fed amazingly. The mom was able to latch. Tears of joy. This is your like ideal golden case that everybody wants to achieve. Here's a few more pictures of kind of what it can look like. Here's your diamond shape, a nice clean incision where the fascia is removed. It'll make a nice closure. Here's what it can look like at 1 to 2 weeks. We're still getting a little closure, but it's looking great. No scarring, excellent healing, and excellent attachment. Let's look at general symptoms for children and adolescents now, okay? When we're thinking about lip ties, all right, lips really don't affect speech, okay? If you think about it, you can hold your lip together here, and really the main purpose of speech comes from the tongue position, okay? So speech really is not greatly impacted by your lip attachment. So that's kind of like a misunderstanding or misnomer at the moment as far as our speech understanding goes. It doesn't really affect eating. You will eat and chew and swallow without your lip having excellent range of motion in children and adolescents, okay? The greatest concern is really going to be aesthetics, okay? Every parent's great concern is when their baby has that giant space between their teeth, or are the adult teeth going to look like that? This is by far one of the most significant maxillolabial frenomes I've ever treated. You can literally see that the frenum is actually incorporated itself into the lipstick part of the lip. And so definitely that needs to be removed for functionality and if we're going to close that at all. Okay. So when we're thinking about the lip, we want to think mostly about cosmetics. Okay. When we're thinking about speech, or excuse me, when we're thinking about the tongue in children, number one, we think about speech, okay? This is a hot topic in speech pathology. Some speech therapists believe that the tongue has a strong indicator in that with a tongue tie. Others believe it doesn't. So just know that that can be a hot topic in your community, depending on your speech therapist or your pediatricians, okay? But we can see children that go through speech therapy for years without any improvement, and then they get through their tongue released and bada bing, bada boom, miraculously, they're now meeting their goals, okay? Or we'll have older patients tell us that that tongue rubs against those teeth and it feels so uncomfortable to them when they're talking as they are coming of age and can tell us those sorts of things. So their articulation and their talking. Airway, 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 airway. As I'm here at the ski meeting, I'm in Telluride. 3 of our speakers today were all talking about pediatric airway development. So it's been a hot topic. It's still very much a hot topic. And so I'm just knowing that we want that tongue to rest on the roof of the mouth to create a great seal so that you can properly breathe through your nose. Dr. Zoggy kind of coined the term tongue up, lips closed, healthy breathing through your nose. And so it's a great little slogan there that we can talk to parents about, talk to healthcare providers about. So I thank Dr. Zoggy for helping us make that so catchy so we can understand how this tongue can really help to impact those sorts of things for us. And if you've got allergies, how are you breathing through your nose? You're going to be mouth breathing. When you're mouth breathing, it's going to cause inflammation to your tonsils and adenoids, and it makes your nose even more congested. It's just this spiraling kind of circle of effect. And that can then affect the bones and how they form. And so it can be a confounding factor that can start in infancy with a tongue tie and a high palate. So you can screen that and help be an advocate for the airway child. What about sleep disorders? Kids that wet the bed, kids that snore, kids that have a hard time going to sleep and wake up, these restless sleepers, your ADHD kids. There's these crazy numbers out there that talk about these ADHD kids might actually be more of these sleep disorder breathing children and need to be screened for that. So we want to be aware of those children in our practices when we're seeing that they're ADHD, when we're seeing these struggles, when we're seeing the anatomical things in their mouth. We want to be thinking about airway, tongue position, jaw position, tooth position. What about eating and cleansability? If you don't think this is a big thing, I didn't think about this at all until Dr. Catherine Flights had mentioned how the tongue is so important. She's a pediatric oral pathologist, and she was talking about how the tongue is so important in oral cleansing to reduce your risk for disease and cavities and getting all the stuff down the throat into the GI and out of the oral cavity. I had really never thought about the tongue like that. And so that was really an eye-opening concept to me when I heard her talk about that. And it's so true. I actually had a patient that had a severe tongue tie and a horrific candida infection all in their upper vestibule. They came to me at around the age of 9. And for a new patient exam, and I pulled back the cheeks and I almost vomited. It was so horrible, all the things that were stuck up there. And I had the patient try to lateralize his tongue. He couldn't get it over the side of the teeth. He's just packing food and is just munching on things, and it just got shoved up there. He's not cleaning his mouth at all. It took us a month and a half to get his mouth healthy again and to get that fungal infection turned around. And a key part of that is releasing the tongue to help the tongue do its job better. I call it the peanut butter test. And so if they can't eat a peanut butter and jelly sandwich and they have to put their fingers in their mouth to help get all that out, we'll probably have an oral cleansing problem. What about quality of life? I think you should be able to eat an ice cream cone and lick it, not have to mouth it, okay? But that's just me. But those are things I talk to the parents about, like how do they eat an ice cream cone? Go home and give them one and watch them. We get these patients that have tension in their necks and their shoulders and have these chiropractic problems, or torticollis. I had a baby with torticollis just this week. Kissing. I talk about it. I talk about with the parents saying, like your child is moving into like adolescence, and these are things that are quality life over a lifetime, and your child is going to be wanting to be a good kisser. And it's going to struggle when you can't get your tongue past your lip. And so it's shocking how many times the mom's like, yeah, the dad's tongue tied too, and that's a struggle. So it's really funny that you kind of think it's a taboo topic, but when you talk about it, the parents are actually pretty open to that in my community where I practice, okay? Or the child wants to feel normal. I've had kids say that I just don't feel like this is how my tongue should be. And then when we release it, they're like giggling because they realize like this is what it's supposed to be. Clinical signs for these lip ties, so things we want to look out for. Definitely the biggest thing is the diastema, okay? I love to release them at this point, this bottom left one. That's a great time to release these as the teeth are coming in. You can see that papilla is palatal. It should be right at the edge of that. Those teeth are going to grow in crooked, and that papilla is going to be stuck backwards. Like that is not the right spot. We know that. There's no reason to monitor this. Get it up and out of the way so that these teeth can come into into a better environment. If you actually look, there's plenty of room for these teeth. This child is V-shaped. They're having a struggle breathing through their nose, and they're developing this V-shaped arch form there. So we want to be looking at expanding for this child and adjusting these tissues, okay? Let's look at this one. See all this gingivitis? It was horrible. So I talked to the mom about how it's going to be uncomfortable to brush this area because that frenum it's tickly and it feels weird and it's uncomfortable to have those bristles rubbed across it, but we need to keep it clean. If we can't keep that clean, then you're going to get cavities and we might need to release that tissue. Same thing here. Do you see these incipient caries across that? When that child was at that point of their age, the mother was not brushing. And so the lip was covering up those areas and we were getting a huge harboring of bacteria in those areas. And so now with some environmental changes, some improvement in diet and improvement in brushing, we were actually able to save those teeth, and the parent opted out of the frenectomy and opted more into home care. I give you the options. It's your child. You can choose. Let's talk about tongue ties in kids. Kind of what clinical things are we looking for, okay? I am always looking to see how they can elevate their tongue on their own and how they can elevate their tongue with my fingers, okay? I love this clicking noise where you go. I want everybody to take their tongue and suction it to their palate, open as wide as you can, and make the click. That is an excellent functional kind of determination for this tongue attachment, okay? And you can really see how the floor of the mouth is pulling on that tongue. And then you can see the mobility of how much can you lateralize it? Can you lick the corners of your mouth? Can you get it all the way up in your vestibules, okay? Those are things we want to be looking at. When you stick the tongue out, does it make a heart shape, okay? Or when you lift the tongue up, can you see all this webbing from the side? Or do you see how far back this frenum goes? Oh my gosh, like it just goes so far back. You're not just releasing the front, people. You're releasing it all the way, okay? And so we want to make sure we're doing a full release, as Dr. Richard Baxter talks about, okay? And so here's another one. As we're lifting this tongue up, you can't hardly get it out of the mouth with 2 fingers and you get this cupping, okay? So we want to be looking for that Eiffel Tower appearance as we're lifting it up. You could play these guitar strings on all of these. You're going to feel that finger-shaped barrier. We want to be looking at other things like that high palate. We want to be looking at that V-shaped arch form. We want to be looking at the mouth breathing. Is the kid just sitting there? Are we actually able to close our mouth, lift our tongue up, and breathe through their nose? I make them breathe through their nose. That's one of the things I make them do. And I'm talking to the parent about how can you expect them to breathe when they can't get anything through this congested nose. Like, we need to be doing something about it. Here's that classic Eiffel Tower appearance where this is the floor of the mouth and all of this tension is on the floor of the mouth. Over a lifetime, that is going to pull down on that gingiva and it's going to cause recession. They've got a lingual bar in that helps them keep from having that go into collapse. There's a healthy amount of people that believe you get that kind of recollapse from those teeth down there from that tongue pulling it backwards. Remember, the bone goes where the muscle takes it. So as we're doing the lip, it's very similar to the baby, just without swaddling them, okay? I like to put them on nitrous. I like to put on a compounded topical, and I like to do a local injection, okay? I use laser glasses over them. I still like to use that MZ5 tip, still as easy as touching that frenectomy setting. I lift the lip up with gauze, just like I did before, and I do the release the exact same way. There's just teeth there this time, okay? So here's one we did that the orthodontist ordered. They were about to put on the power chain and they didn't like how low this was. They wanted it up and out of the way. So we released it up. It healed beautifully in 1 week. Okay. Here's one that we did as these permanent teeth are coming in and we can see that those are in and this big beefy tissue's in the way. You see how short it is? Like you can't even lift the lip up. It's like literally glued to the maxilla. So we took this one really far to be able to get that lip all the way up. So it makes that classic diamond shaped again. And we want to be taking those post-op pictures and massaging across just like you did with the baby. Here's that same case. This is probably the most severe one that we had. This is the InRepose. This is it with me lifting it up. You can see how it's pulling down. And this is 1 week after we took that kid from this to this in 1 week. It was beautiful. Do you see how we recontoured down here and we made sure we recontoured up here on the top lip so you don't end up with any tissue tags, okay? For the tongue, it's the same thing once again for the babies, okay? Just a little different. So we can use topical and nitrous and local if you want. I still lift the tongue up with the groove director. This is what that tongue click looks like, okay? So I took a picture of what it looked like with that. All right, so you can clearly see where I need to cut. Sometimes I don't do the groove director and I just have them do that suction. And I'll cut, cut, cut as they hold it. Cut, cut, cut as they hold it. And what a beautiful release that you get. And now the child can functionally lift their tongue all the way up to the roof of their mouth at max opening. So we took them from less than 50% at max opening to now full, okay? This tongue is almost completely closed in function, and that's why I love those post-op exercises, because it helps it functionally when it closed, and we don't need sutures, okay? Let's take a look at a few cases here. So here's our before picture. So we can see how it's tongue tied through here. We can see how we're able to elevate the tip of the tongue, but not the entirety of the tongue. And this is where we're making our incision, not here, not here. I like to make it in the middle, okay? You're staying away from all those vital anatomies and you keep a clean surgical field, okay? I release it all the way back and release all these fascial fibers. So all the little webbing in between there are the fascial fibers. It is not just a fold of buccal mucosa. There are fascial fibers that have to be released to help this heal. So you're not just cutting the tissue, you're cutting, or the superficial mucosa, you're cutting the fascial fibers, okay? And that's what makes the tension. Here's another great case. As we're elevating, we can hardly get this tongue up. I mean, this might be 25 to 30%. This would be at 50%, but you're getting that cupping of the lateralization. Do you see how there's a V shape right here in these central incisors? That tongue will stick right through that shape, okay? This is immediately after we released, no more cupping anymore. The patient is actually now able to stick their tongue all the way out. If you look very closely, right down here is where it was attached there. They are getting that tongue all the way out. An instant extension, and a beautiful heal at 1 week. Here's an adult case I did. I hardly ever do adults, but this one was a beggar. And I felt really bad for him. You can see how he's been living with this very short lingual frenum. Once again, it's going to fit right through this space right here. And you can see how it just runs into those lower incisors. You can see how he's not able to elevate it, probably more than 25%, like literally even the tip is held down. Instantly after the procedure, what I want you to see is how yellow this is. The older the patient, the harder and firmer that those fibers are going to get, that the fascia is. They're not as flexible as the babies and the children. So if you treat adults, you're going to notice that that fascia is going to be tougher and they may need more body work to help work out those kinks. This is instant extension. He went from this to not even being able to get it past the incisors to now getting it straight out to a point. It's pretty impressive. One last case here. I love this. The kid can't even raise his tongue. I'm like digging it out. Like, this is why you don't cut at the base of the groove director. That is tongue. That is muscle. Okay. Your incision is here. You incised all the way back. I didn't just make a clip at the front. We went all the way back, and look at that beautiful heal in 1 week. Last little thing here I want you to hear about from one of my favorite patients.
I'm 14 years old and I was having under tongue issues that we talked to Dr. Curtis about.
Can you tell me some more about those issues you were having with your tongue?
A few of those consist of a lot of pressure under my tongue when trying to get food out of my teeth, a lot of pressure when trying to touch the roof of my mouth. And although I didn't have speech issues, it was a little harder saying a few words because I feel like I was tongue-tied a few times. Yeah.
What about pressure in your neck? Did you feel like you had some pressure in your neck before? Yeah. And then we did the release about a week ago. And can you tell me how it's been? Can you tell a difference?
Yes, I can tell a difference. I feel like I've been speaking a lot more clearer. And it's been easier to reach the roof of my mouth and to get food out of my teeth. And there's been less tension on my neck, and it's been great.
How was the
right after release? Was it really uncomfortable, not so bad? Tell me more about how that was.
It was uncomfortable for about 1 or 2 days. But after that and doing my exercises, it really helped. And I started to feel less tension, and that's when I started to see more of the benefits.
Big question, would you do it again?
Yes.
Perfect. Thank you, dear.
Don't you love her? She is what I like to call growing a frenectomy. We knew when this child was so much younger. She's been a patient of mine probably since she was like 8 or 9. We've identified through our clinical notes all along, we've been worried about the tongue, but no speech issues, no concerns from the parents, no concerns from the child. She finishes orthodontics and the tongue box is perfectly molded. And now the tongue is running into that because all the compensations from the arch, from the tongue and the muscle pulling on it have been ironed out. All the kinks are gone. And now the tongue is running into the mountaintop and she doesn't like it. She chose to have a frenectomy. She came of age. She knew she needed it. She knew that didn't feel right and she loved the results. Look at that smile. If you don't call that a quality of life win, then I don't know what is. What you can't see here is the mother was off to the side sobbing because what we didn't see before was her articulation issues. She talked fine, but it was not as clear as she talks now. 1 week later, it was mind-blowing for the mom that she sounds like a news anchor and she didn't sound like that before. You'll notice that at the bottom of all of my slides that I put learn, do, serve, because I believe we never stop learning so that we can do good and better serve our patients and our communities where you are. Thank you so much for your attention tonight. There's quite a few questions in the Q&A, and I'll do my best to plow through those. Here's my information. You can follow me on social media. I post a lot of cases on there. So if you got questions about those, I run my own social media accounts. I will respond to you on there. Or if you want to email me, I'll try to dig through my avalanche of emails every day and get back to you. But I'll open it up for Q&A now. One more thing I'll say is, join us in Scottsdale for tequila and tongue tie. It's going to be a great time. I'll turn it over for Q&A.
All right. Thank you, Dr. Curtis. Wonderful lecture. And we do have quite a few questions that we want to get through. So to our audience, if you would hang on here for a few minutes, I want to make sure that we recognize everyone who posed a question to Dr. Curtis, and then we'll go through our closing information for you. So first off, Dr. Curtis, there were quite a few questions just about, anesthetic that you use, topical. So there's probably 3 or 4, maybe even 5 questions on this topic. So why don't you just go just a bit further into that to give everyone what you use in your practice?
I use a combination of lidocaine, tetracaine, and prilocaine. And so you can have it compounded from the pharmacy. If you look, I normally always put the slide in there, but I had to condense this down. As you see, I made it with 3 minutes to spare. So I cut out the compounded topical prescription formulation at the last minute. I'm sorry, I knew better than that, but I can't remember it off the top of my head, but it's like 23 and 3 or something like that. But you can look it up online, a compounded topical, and it will give you that percentage and the exact ones. You can call up any pharmacy and they can make it for you. My local pharmacy makes it in a big tub for like $60. It is game changing, okay? And so I don't use just the plain old bupivacaine. Like, you don't want to use that benzocaine. It's not good, okay? The compounded is great. I do not numb for infants out of the fear for methemoglobin. The best topical ever is wonderful. I just saw that come in, but I can't get that where I am, but it's a similar formula to that. Or TAC, you can hear it called TAC, T-A-C, it's about the same. I don't numb for my infants out of the concern for methemoglobinemia, but I do numb for my older children just because I might be going deeper. So I give like 1/10 of a carpule of lidocaine for my child and adolescents after I do the topical steroid or the topical anesthetic. I do a little bit of numbing. I don't want to balloon out the surgical site, so don't give more than 1/10. Just a little goes a long way.
Great. And to the audience, if you email education@biolase.com, we'll try to make sure we get you the appropriate information
I'll
for
also
that.
mention that there are many webinars on our pre-recorded that I've given on these different subjects, that information are on these other webinars that are available to you through the Waterlase Academy. So those are all there online, provided by Biolase. So it's buried in those in multiple of the lectures. I just cut it out on this one for time's sake.
And there was a question about sedation. What kind of sedation do you use? Do you offer sedation?
Normally I get these done with just regular nitrous oxide and the child sitting in the chair. I try not to do a lot of oral sedations for these, not because I don't believe in oral sedation for them, but if I'm having to oral sedate the child, it's normally because they're not cooperative. So if they're not going to be cooperative for the procedure, how can I expect for them to be cooperative at home for the parents to do appropriate exercises, stretches, and home care for it? So you're just kind of shooting at the hip and hoping that biology helps you. So I don't really like to be as kind of willy-nilly with it as that. So it's more about patient selection for me. But if I am IV sedating a child and putting them to sleep in office with IV sedation and they need a tongue tie, I will do the tongue tie. I may stitch it back to prevent them from having to have that. So if I was going to be putting them under an oral sedation for that, like Versed or Demerol and hydroxyzine, I would be leaning more towards suturing that close so that we don't have to do as much of home care.
Great. There was one that was posted during your lecture that I thought was good that we should address. It's about how you stabilize not an infant, but a 1 to 3 year old
You don't.
during the procedure.
You don't stabilize a 1 to 3 year old. You would have to papoose them with a head papoose, with one of the big wrapped up papooses with a head piece to it as well, to keep that 1 to 3 year old from thrashing all around. The indications for doing a 1 to 3 year old are very low for the most part, meaning that speech is still just developing on a 3 year old. And so it's hard to say, like, is it the tongue? I've done a few 1 to 3 year olds and they are bloody messes because the child screams the entire time. It's impossible to suture them without putting them to sleep. And so home care afterwards, they'll bite you. So the parent can't get in there to do any post-op stretches. And I have just not found great results with the 1 to 3 age range. And really the indications in those areas are much weaker than if you wait to 5 to 6 when, excuse me, development catches up to more of the appropriate kind of milestones, and we can determine the better route to go, whether it was speech therapy for a few years, where we can start at 3 speech therapy. So I'm advocating for therapies, I'm advocating for things like that. And if the child really needs that, like we're having all these eating issues, this and that, I don't really like to papoose them to do it that way. I would send it out to a GA situation or IV sedate them in office for that and suture it closed. So that's how you'd stabilize them. You put them to sleep or you would have to papoose them.
Great. And, going through kind of a theme of some of the other questions, there's quite a few questions about exercises and assessment tools that you use. Now, I know that we have a protocol and I can point people towards that here in a bit, but maybe you can take on exercises and assessment.
Yeah. So with Biolase, Dr. Cherish and I have put together a protocol for frenectomy. It's like a little pamphlet where it kind of walks through like our favorite exercises, our favorite like assessments, things like that. I love that Dr. Richard Baxter has a lot of online things for you just from himself through all of his things through the Alabama Tongue Tie Center. And so you can actually download his tongue tie assessment and you can go through that and adapt it for yourself. Biolase has their own tongue tie assessment that we've adapted as well. So that's readily available for you as well. I love a good assessment tool. It's really great to give the parents a check-in, or the pediatricians can give it to them as an assessment tool as well. And you can brand it with your own logo on that. So I love that. As far as post-op exercises, there's a plethora of different things that you can go through. My favorite one for the baby is just lifting the lip to the nose, or the adolescent too. So you're just literally lifting the lip to the nose. I like to do it 10 times, 4 times a day. So you do 10 reps 4 times a day for 2 to 4 weeks. But you're going to come see me at 1 to 2 weeks, and I'm going to tell you how much longer to do it. For the tongue, I like to do the tongue clicks. For my children and adolescents, I tell them to do it preoperatively so they can practice it, so they can get the muscles used to that, so that they're better at it afterwards. I always find that my speech therapy kids are so much better afterwards because they have so much better control of their tongue. So I love a child that's been through therapies and trainings of the tongue, and then we release it. So that's really helpful to get them off to the races better. You can also do an extension exercise where you can take a small little glass, like a shot glass or a disposable cup, and you can have them stick their tongue through it and lick it. And that can also be a very helpful way for them to extend their tongue. For the babies, I stick my fingers under there and literally feel like you're rolling it back in their throat. So you're elevating the tongue with your fingers.
Great information. So before I do have some resources to point our audience to. I tried to pick up on one last theme of the questions. Thank you, everyone, for the nice questions. A lot of engagement here. This may be difficult, Dr. Curtis, but there were quite a few questions about, well, the Waterlase versus the diode versus the blade. And I know this may be difficult to summarize, but maybe just touch on the differences in performing this procedure between those modalities.
Of course. I would never stick a blade in a baby's mouth, first and foremost. Like I just find that would be very dangerous. So I wouldn't do that. You can do scissors. It's tough with scissors because you almost get just one shot. It's hard to make multiple cuts with the scissors, and you need to make sure you have like the springy scissors, okay? Not just like they need to be the little surgical spring ones that they can open and close. So scissors are great, okay? They can be very good, but they can be kind of hard to use. It's really hard to make the full release with those. And so they've kind of fallen out of fashion for that reason. And they induce quite a bit of kind of a little bit more post-op inflammation with the trauma from the cut, okay? With the diode, there's a lot of heat that comes out of that. It's basically like a hot paper clip. It doesn't cauterize the area, but it chars it and it looks like a cigarette burn. So no one wants you to burn their baby. Okay, if there's another way to do it, you do the best you can until you can do better. Don't burn a baby, okay? So I am not a fan of the diode. For one, it smells terrible and it looks terrible afterwards. But you do get more, a little bit more post-op inflammation, a little bit more risk for scarring and things like that. With the erbium laser, which is the Waterlase laser that I use, the depth of penetration of that laser is literally like 10 cell layers, 5 to 10 cell layers. The diode goes like 50 to 100. The scalpel or the scissors can go to over 100 to 500 cell layers. That means the more trauma you get to the tissue, the more post-op inflammation, the more pain. That pain cascade, if you think back to biochemistry many moons ago, it's inflammation, it's scarring, it's pain. So the less trauma, the less necrosis that you're going to get from that necrosis cascade, the better healing you're going to have, the better post-op experience. And so that's really where this laser comes to shine, is because it's so minimally invasive. It's cool.
Great. Good job summarizing that. So